Okay, perfect.
Hi guys, welcome to UMDcast episode 4. Today we'll be interviewing Dr. Jacobs, a vascular surgeon at Weill, Cornell. Thank you, Dr. Jacobs, for speaking with us this evening.
Thanks for having me.
Okay, we're going to start by, if you don't mind, can you please give us a little background about your education leading up to your current position?
Sure. So I went to college at Barnard College in Columbia University in New York, where I was a American history major. I wasn't really planning on going to medicine when I started college. I didn't have a lot of exposure to doctors. There weren't a lot of doctors in my family. I knew I wanted to work with people in some aspect, but I wasn't really sure that I wanted to go into medicine. And I loved history, and I ended up being an American history major. While I was at Barnard, I did take my pre-med requirements sort of as a just in case I wanted to go to medical school. And I had a friend who was going to medical school, and she sort of kept me in the loop of what I needed to do and what I needed to take in order to apply if I had decided to apply. While I was in undergrad, I did really enjoy my science classes and the pre-med requirements. And I thought maybe I wanted to do physical therapy. And I did work one summer with a physical therapist and decided that although I liked working with patients, I didn't necessarily want to do that for my career. I felt like I wanted to, I guess, be more in charge of the overall medical care, where a physical therapist, I felt maybe I didn't have as much opportunities to do as much with a patient. So again, I wasn't 100% sure I wanted to go into medicine, and I sort of wasn't sure what to do, but knew I wanted to work with people. And medical school was another 4 years of learning about, the human body, which sounded really interesting to me. And I knew that I could put off making a decision of what kind of doctor I wanted to be for another couple of years. So eventually, when I was made that decision, I did take my MCATs. And then I went straight to medical school. I was lucky enough to have taken all my requirements in undergrad, so I didn't have to do a post-bac or anything. I ended up going to George Washington University for medical school in DC. And the first 2 years is very similar to college in the sense that you're sitting in a classroom. Although I think now they've changed it and they've tried to make it a little bit more clinical, so you get a little bit more exposure. And then third and fourth year is a lot more clinical. And it was during that time that you have more exposure to the different fields of medicine that you can make a decision of what you want to go into. So they have different rotations like peds, internal medicine, OB, surgery, and I ended up loving my general surgery rotation. I love the fact that people came into the emergency room, had a problem, they were sick, and then you did an operation and fixed them, and they got better, and then they left. It was very exciting. So I ended up applying for a surgical residency, where I then came back to Mount Sinai in New York and did 6 years of general surgery there. Do you have any questions about my background so far, or that sort of?
No, it's been that's awesome. It's been very clear.
Okay.
You're just
Go ahead,
curious.
sorry.
Did you ever have like a mentor during your residency or during your what's it called, med school, that like helped
Yeah.
you
So
in,
so that's a great question. I feel like a lot of times you end up making decisions based on people that you're exposed to, which I think why this podcast is great. You're getting a lot of exposure to different types of doctors, especially if you guys or the people listening don't have a lot of doctors in their families or don't have friends whose parents are doctors. So I think part of the reason why I loved surgery so much was, you end up as a medical student being paired with a resident. And I think the residents that I worked with on my surgery rotation probably were, sort of mentors to me. And, they were so enthusiastic about surgery and so excited about surgery. And then when I showed a little bit of interest, they actually, helped me and, would work with me on the side. So like if you're trying to learn how to suture as a medical student, they would say, oh, let me help you. And then they were so enthusiastic about, being a mentor for me. And, when it came down to it, to helping me apply for residency, that's probably one of the reasons why I chose surgery, not just because I love the field so much and actual like healing patients and fixing a problem, but I did have mentors as residents. They're a couple of years older than you. They've gone through medical school, and they were anywhere between 2 years into residency to 4 years into residency. So general surgery is usually 5 to 6 year residency program. I applied to general surgery, and like I said, I went to Mount Sinai for general surgery, which was an amazing program. I had a great general surgery training. And during that time, you are exposed to a lot of different fields in surgery. And again, the whole mentor question, comes up. So you definitely are exposed to different attendings who are the doctors that are done with their training already. And I did have probably a few mentors, not just your senior residents, but also some of these attendings. And Mount Sinai had a very strong vascular surgery division, and they also have a very strong colorectal. And I really loved all the fields, but there was one particular mentor who sort of took me under his wing. I ended up doing a year of research with him, and really got excited about vascular surgery in that way. And that's probably how I ended up in vascular surgery, was because of that mentor, as well as the actual operations that are done in vascular surgery. So I guess if you I know you were going to ask me about, was there a particular moment where I knew I wanted to be a vascular surgeon? I think part of my decision for vascular surgery was, so just, I guess, since you guys are in college, vascular surgery is operating on all arteries and veins outside the heart. So you're not operating on the heart, but you're operating on the aorta, like the abdominal aorta. You're operating on the carotid arteries, which bring the blood flow to your brain. You're operating on arteries and veins in the leg and the arms. So one of the very exciting things about vascular surgery was that, any operation, you could be operating on a different part of the body. You could be in the neck one day, in the leg, in the arm, in the abdomen. And that was exciting. Where if you did something like ENT, you're really just in the head and neck, which is still amazing anatomy, but this is sort of gives a little bit more variety of where you're going to be working. And it's technically challenging because arteries and veins can be very small, and you have to, have very, precise and attention to detail, and be very careful and technically excellent in order to make sure that your, anastomoses, which are putting two arteries together or an artery and vein together, so it was technically challenging. And I think that also was exciting for me. And I like that aspect of it.
Thank you for giving us some more background and some more insight into the field. That's very helpful. I actually wanted to move on a little bit and talk about just kind of what the work environment's like as a doctor. I saw that you had worked for a private practice before joining Weill Cornell Medical Center. Is there anything that you like better about one compared to the other, or were they just both good in different ways?
Yeah, sure. That is a good question. So when I first finished my fellowship, I actually did stay on staff at Mount Sinai, and I was in the academic world for a while. And then I went into private practice, and then I ended up coming back to academics. So definitely pros and cons to both. The private practice, you have a little bit more control over your hours, your workspace, your work environment. But what I found that I missed, I loved the time I worked in private practice also, but I worked by myself. I didn't join a private practice. I was a solo practitioner. And I definitely missed having the camaraderie of other, surgeons to talk to run cases by, to discuss, difficult cases or just interesting cases. And I also missed some of the teaching aspects of academic medicine, where you're working with residents or medical students. So yeah, that's why I decided to then come back into academics and have that opportunity to do a little bit more teaching.
Amazing. So our next question, we were all kind of curious about the procedures you perform on a regular basis. Maybe if you could just like walk us through maybe the most common procedure you perform or your favorite one.
Sure.
Perfect.
Okay, so like I said earlier, vascular surgeons work on arteries and veins anywhere in the body outside the heart. I actually now only do venous work. So about 9 years ago, I stopped doing the arterial work. I could say that, probably what I liked about the arterial work, a lot of people say they love doing carotid artery work because the anatomy in the neck is so interesting. But right now, like I said, I only do venous work. So the main procedures I do now are for like varicose veins or spider veins or venous malformations, which are, abnormal collections of veins somewhere in the body, whether it's the arm, the neck, the leg. I primarily work in probably the leg and the arm is probably the two most common places I work. So that's what I do now. So I do a lot of outpatient procedures and see a lot of patients in office hours.
So when you're doing these procedures, do you tend to see a lot of the exact same procedures, or when you're doing something for varicose veins in one person, would it be different from person to person?
So the majority of the procedures are, the procedures you're doing are pretty much the same procedure, but every person is a little bit different. But the actual procedures are the same. It's the same thing with like, the arterial work. If you're going to do a bypass for someone who has, poor circulation in their leg and there's an artery that's blocked, you're always going to have to, whether you're going to, you want to bypass that area that's blocked, you're going to have to take some sort of conduit, whether it's a vein or it's, graft, and attach it above the blockage, and then, anastomosis it below the blockage. But what makes it interesting is that everyone's anatomy is slightly different. Everyone's disease is slightly different. So it's the same thing, with varicose veins. Most people's veins that we're treating are, the veins are in the same areas, but everything's just like a slightly different. So there is some variety in every patient, but the procedures are pretty much the same. So you do end up in a lot of the fields that you end up going into, you end up sort of getting into just a niche, and you like end up doing the same type of procedures over and over again.
Mm-hmm. And do you ever get like burnt out or bored of your job, or do you just always find it interesting every single day, even if it's the same thing, because everything's slightly different, it never gets old?
That's a good question. I think probably everyone gets a little burnt out. I happen to love working with patients. I really love what I do. I think I'm very lucky. Even during my crazy training in residency, where I had really, really long hours, family members would say, wow, you're so happy, when you first come back from work, like, because it's really exciting taking care of patients and helping people. But I feel like, in any job you can get burnt out, but that, when you have coworkers and partners, they sort of help you through those times that get a little bit more difficult.
Yeah, I was actually going to follow that up with, when you do have those times, how do you usually cope with it? Is it like you have something that you love doing? You talk to your like friends, family, and coworkers about like their experiences with this?
Yeah, I feel like there's I don't necessarily think I get burnt out because the procedures are the same. It's not like a boring thing, like I said, because you see so many different patients and everyone has some sort of slightly different kind of disease process. And that always keeps it interesting. I think sometimes people could just get burnt out from work in general. But yeah, you have to have a good support system in any field that you go into, really in any job, but specifically in medicine, which I think can be a little bit more grueling. So it's important to have, you know, family and friends and partners that can help you through those harder times.
Thank you too. Thank you, Dr. Jacobs. I was curious, for someone who like loves biology, would you mind going through like a brief procedure you mentioned of putting like two veins together, or like that's something that's really interests me and would love to hear like more about what that procedure entails.
Sure. So when I was discussing the bypass procedure, it's one for a blocked artery, like I said. So I really do venous work now. So I'm pretty much destroying or removing veins that aren't working. But the putting things together, it's called an anastomosis. So you're sewing like an artery to a vein. And you do that for, or an artery to an artery. You know, you can do it in trauma if, you know, someone shows up with a gunshot wound or a knife wound and there's trauma to an artery and you have to put it back together. Sometimes you could, you know, sew the two ends together if they're not too damaged, or clean up the damaged ends and put them back together. You know, the main, or sometimes you have to use a piece of vein in order to, if the area that's damaged is too far apart. But the technical aspect of the anastomosis is, you know, making sure that you just sew it very carefully. And I guess you learn all of that, you know, while you're doing your training. But it's, trying to think how to explain it better, but you just have to sew the two ends together carefully. You're talking about the different materials you use. Like, I mean, there's suture that keep it together.
Yeah. So
and then
like,
eventually your body sort of heals the area so that it incorporates it into, you know, a nice anastomosis.
so like, I was also curious, like you're working with veins and arteries that obviously carry blood. Is it
Right.
to see what you're doing? Like, how do you clear
Oh,
out exactly?
right, exactly. So whenever you have to open up an artery or a vein, you actually have to get what's called proximal and distal controls. So you have to actually, if you're working on one area, you have to go above that area and below the area, so that you can actually control it with some sort of device, so that you can actually close the artery or the vein in that area, so that when you open up the arteries and the veins, there is no blood flow coming through it. Because yes, it would be very difficult to sew while there's blood running through it. It's so funny that, like, I didn't even think, you know, to me that's a great question that you're asking, because, you know, you haven't seen it yet, and obviously that would make sense. Like, how can you sew when there's blood in the field? But, you know, everything you do in vascular surgery, you always have to have a clean field and, you know, a dry field so that you can see what you're doing. So there are ways to control the blood flow with clamps and different devices so that you can sew in a clean field and you can see.
That's really cool. So we were just wondering, because like, I guess because the podcast is kind of meant for people who are interested in pre-med, and I guess a lot of those people kind of expose themselves to what's in the media and what's on certain TV shows. And on TV shows, I guess in the operating room, they really like dramatize certain times, I guess, and like highlight really frightening times in the operating room. So we were just wondering if you had like what your worst experience was, I guess. And if you don't have one, then you could do your best. We were curious.
Right. So, yeah, there are definitely times that are very exciting. You know, you prefer, once you're the attending and you're responsible, you know, you definitely prefer the calmer moments. You like everything to go as planned, but, you know, there are times that are a little bit, that they're a little bit more exciting, let's say. I mean, for me, I have to say that probably the most stressful operating rooms that I've been in was during my general surgery training, where we did trauma call. And I think dealing with gunshot wounds and, you know, bad trauma is definitely stressful. Since it's not so cookbook, like, you know, you asked me the question about, is surgery, does it get kind of like boring if you're doing the same thing over and over again? So, you know, you have a operation that you want to do, and, you know, for a certain disease process, and it's, you know, you do A, then you do B, then you do C. And trauma, even though there are the ABCs of trauma, and, like, you know, you have to follow sort of a cookbook, you never know what you're going to find when you bring the patient to the operating room. And that's definitely the more stressful moments I've had.
Thank you. And going back to what you were saying before, you were talking about how you remove veins sometimes. What is the physiological consequence to removing a vein? Does that like cut off the blood supply from some tissue and cause it to die, or is there just other ways that the body adjusts?
Right, great question. So we have arteries and veins in our body. Our heart pumps all our blood through arteries. So all of our tissue gets blood, oxygenated blood from our arteries, and the veins bring all the blood back to our heart. So by me removing a vein, I'm not necessarily decreasing the blood flow to the tissue. It's, you know, it's how does the blood get back to your heart? So any vein that I remove, or I, you know, for lack of a better word, destroy, or somehow, you know, take out of the circulation, your body finds more efficient ways of getting the blood back up to your heart. So for varicose veins, the idea behind it is that you have a vein that's not working properly. So, you know, in your legs, the veins have to work against gravity to get the blood back up to your heart. So they have valves in them so that the blood moves up a certain portion of the vein in your leg, and a valve closes, and then moves up another portion of the vein, and the valve closes to prevent the blood from being pulled back down by gravity to, you know, your foot. Over time, and for heredity reasons, those valves don't work as well. And some of the blood starts to like pool in the lower legs and can cause different symptoms of heaviness, a tired leg. Some varicose veins develop. So those veins aren't really working so well. So those are the veins that I usually deal with. Any vein that you need, we leave in your body. We don't remove or destroy. So if you take out one of these veins that are less efficient or not working well, some of these superficial veins, then your body really finds more efficient ways of getting the blood back up to your heart.
Thank you. Well, it seems as though we only have 7 minutes left on the Zoom, so I guess we have time for one more question.
Sure.
So the question I have is, have you seen your demographic changing with time? Because I know there's like the whole obesity pandemic in this country. Do you think that you've seen that as a risk factor for people who have any sort of vascular disease or anything? Or do you see typically more of a geriatric population?
So again, my what I see now is going to be a little skewed since I do more of the venous work. So I still see a lot of young patients, or, you know, a lot of women, or who've, you know, you have an increased risk of developing varicose veins with pregnancy. So, you know, I see probably like younger 30, 40-year-old women, also men. A lot of doormen have varicose veins, or any job that you have to stand for a long period of times, doctors, teachers. As far as the arterial disease, you know, the main things that contribute to arterial disease and atherosclerosis is going to be smoking, high cholesterol, and diabetes. Like those sort of things increase the risk of developing you know, plaque buildup in your arteries and having disease in your arteries. Obesity is definitely, you know, a problem for multiple areas in medicine. I'm not really sure it's changed the demographic for me. You know, probably what changed more in vascular surgery is that there's so many techniques and procedures you can do endovascularly, which is, you know, sort of like when people do stents in the arteries around the heart. So a lot of the procedures now are done in a minimally invasive way instead of doing much larger operations. And that sort of happened during my training. And now there's a lot of medicine coming out. Like, so if you can control, you know, your diabetes, and the medications for high cholesterol are much better now. You know, hopefully with those advances in medicine, you can change the disease process within the arteries so fewer people need operations and need vascular services.
Sam, that was a great question. I really liked your answer, Dr. Jacobs.
Oh, thank you.
I think we're gonna end the episode now. Thank you so much for meeting with us and answering our questions. We really appreciate it. And have a great
My
night.
pleasure. I think it's great what you're doing, getting exposure to undergrads, helping them figure out what they want to do.
Thank you. Really appreciate it.
Okay.
Thank you very much.
Thank you so much. We all learned a ton.
You're welcome. Bye-bye.